Hi, everybody. This is Dr. Ed Park. Today, we're going to be doing a provider webinar about back treatments. Uh, I get a little bored of the first slide, so I'm trying to switch it up. For people that don't know, I went to Harvard undergrad and residency, and it was at that OBGYN residency. I saw so many epidurals. They had us practice some, so perhaps that's why I feel a little more comfortable doing them. As you know, probably 34% of women get an epidural in labor. The picture is 10 years ago, my boys doing that forced perspective thing. I guess the Eiffel Tower has stood up for a lot of years, and just like that, our back is a structure that needs to stand up for a lot of years. We'll talk about how to do that. I went to Columbia for my master's in public health and my MD degree. In 2016-17, I was consulting for uh, a high net worth individual who wanted to do anti-aging with exosomes. All that changed when I heard my colleague, Dr. Jordan, talk about his motorcycle accident, his remarkable healing. So I tried it on myself, and indeed it helped my meniscus, my rotator cuff, and my Achilles. So then over the years, I've expanded to friends and family. I forgot to update the procedure, but over 2,500 procedures now, and we create an online training course that doctors can learn from. We also do online site training in the 6 states in which I'm licensed. Finally, I did write a book and narrated Exosome Songs of Healing to explain at about an eighth grade level what exosomes are. To recap the size criteria, there's big, there's small. We're talking about something that's invisible, quite literally. Abby's limit of light is 200 to 250 nanometers. That means for some reason you cannot see below 200 and 250 nanometers. You can see with an electron microscope, but you're not seeing with light itself. So these are tiny 100 nanometer, invisible when you thaw lipid spheres. Inside they have mRNA. They're made in the Golgi apparatus. As you can see above, they're in batches of 1 to 2 dozen of these little balls within an MVE. And they're about 1 to 200th the diameter of a real cell. They're not cells. So arguably, they're not even anything different from fresh salad or unpasteurized milk. There's exosomes everywhere. There are thousands of studies to suggest, tens of thousands, that disease states, healing states, good states, everything in the communication is mediated by exosomes. So when you do go below the light limit and use an electron microscope, this is what they saw, and they saw this for many decades, and they just assumed it was poop, much like if an alien was looking at humans and they saw us, they'd see we make poop, they would think that was our only raison d'etre. Last week it was Tesla. This week it's William Shakespeare on the loo, uh, typing out a sonnet. Certainly he and we would not consider his cellular communication to be poop. So you grow stem cells in these pentagonal flasks. You grow them with stem cell medium, fibroblast, fibroblast growth factor 2, certain oxygen conditions. And then every 2, 3 days, you filter out the water, wherein lie these tiny exosomes that you can filter with a tangential flow filtration. I allege, and most people would not argue, that exosomes are how we heal, a big part of it anyway. So when you get injured, your body will create inflammation, stem cells will come and secrete exosomes. And through this, they get cellular communication, mRNA, proteins are released, they reprogram, they cause dedifferentiation, extracellular matrix and vascular proliferation, Th1 to 2, M1 to M2. So anti-inflammatory effects. And so the old days of PRP leading to inflammation and stem cells, you don't need those first three anymore. We just need exosomes, I believe. I learned this year at the conference in Australia from 1,000 PhDs, brilliant scientists from around the world, that there are even larger EVs, and they may have the same contents as the smaller ones. And the really large ones can actually share important things like mitochondria and things like tendons and retina. So again, you've seen the octagon. I blew it up for you. It just shows that if you look at scientific research on diseases, the outer ring is macular degeneration, infertility, wrinkles, cancer. All these things are related to short telomeres. How? Because their stem cells mutate, because they get old and get damaged, and the driving force of this, I allege, is shortening of the telomeres. That's why we say it's one disease with many faces. So 80% of people have back pain. I've had back pain twice in my life. It's a leading cause of disability. It increases, of course, with aging. Witness the octagon above. And why is that? Because the stem cells that create and maintain the bone, the ligament, the muscles are all degenerating as we age. I've been playing with the AI. So you see at the bottom the gymnast and the lady with the osteoporosis on the right. The only difference is time. And this is what AI came up with, a hourglass with stem cells literally being depleted. So if we look at the evolutionary tree, we have pre-chordata tunicates, right? We got lancelets. Then we developed a backbone that broke us off from jawless fishes. Then we got jaws, no pun intended, and that set us off to fishes. With a bony skeleton, we diverged from the cartilaginous fish. And then we got lungs, which made us not fish or amphibians. We got limbs, got amniotic egg, and then mammary glands. So that's the tree. Why do we need a back? We need it for structure. It connects the pelvis to the shoulders, uh, and it protects our internal organs with the ribs. We also have the neurological function. It's the conduit for our nervous system. Cranial nerves, also peripheral nerves, autonomic nerves. Gives us feedback, gives us control of our body and its organs. And finally, it's for movement in all axes. This is allowed for by the segmentation of the vertebrae, the discs, the facets, the muscles all allow us to bend and twist and do all kinds of amazing things like the gymnasts. Excuse me. So what is the normal anatomy? Well, Netter above are great excuse me. Netter above, these great illustrations that he made in the middle of last century show that the spine is composed of four segments. Really, maybe there's the fifth coccygeal, but you have lordosis, which is curvature away from the belly button, and that's in the neck and in the lumbar spine. And then you have kyphosis, which is curvature, I guess, towards, that's the thoracic 12 vertebrae and the coccygeal 5 vertebrae. They're connected by discs in between. Of course, the coccyx, their discs are gone and they're fused. We have joints in the facets that's shown directly above me. The facets are what connect the vertebral body above and below. And we have muscles. Also, there are mechanoreceptors, and homeostasis is maintained through posture and these tiny adjustments, almost like a watch timepiece. So this is what AI came up with, watch timepiece back muscles. You know, I can't even say I ever learned these tiny back muscles, but there's the intertransversalis going up and down between the transverse processes. There's the rotatores. There's the multifidus. They're tiny muscles that are adjusting, maintaining, and of course, these are all subject to depletion and deterioration. If we look at the ligaments, there's the anterior longitudinal ligament, that's towards your belly button, on the front side of the vertebral bodies, the posterior longitudinal ligament, and then at the other side of the spinal canal, where the spinal cord is running, we have the ligamentum flavum, and then we have the transverse processes. There's an interspinous ligament, which we'll go through during our epidural procedure, etc. Last year, we talked about, excuse me, last year, what am I talking about last year? Why is that cropped? Okay, it's okay. Okay, last week we talked about the hips, and I did mention my back pain, which came from riding the scooter. So what happened was for 6 months, I scooted everywhere, didn't walk. My abs got weak, my glutes got weak from not walking, and this caused problems in my posture and my ability to support my trunk and to do hip flexion. So the lady wears a girdle, the man wears a girdle. So our girdle effectively, at least in the torso from the pelvis up, are these back extensor muscles, and in the front, the abdominal wall muscles. So if you're walking, if you're doing Pilates, then you have a strong core, you have less back pain because you don't have this problem of weak abs and glutes, and then tight back extensors and flexors. So what causes back pain? Well, there's a myriad of reasons you can have back pain. They range from fractures, collapse of discs, protrusion of discs, facet arthritis, damaged ligaments and muscles. We can also have altered alignment from scoliosis, from muscle problems or asymmetry, damage to the bones, osteoporotic collapse like beer cans, joints, ligaments, muscles. And all this leads to more problems because with the pain and the reduced flexibility, you exercise less, you have less strength, less postural support, and you have less pliable ligaments. Above us, good posture in the middle is flanked by bad posture, flat back, sway back, weak abs, rounded shoulders. Of course, sitting at a computer all day doesn't help. So a lot of people use standing desks. Some people have apps to remind them to get up and stretch. All good. The motions we see to my left are motions that you should be able to do with a healthy, flexible back. And indeed, when we see the older women, but also men with the posture in their 70s and 80s, this is what's happening. The actual vertebral bodies are collapsing like beer cans because of osteoporosis. So, what is usually the symptom that brings them to the doctor? Well, it usually has to do with it usually has to do with nerve root compression. And unless it's spinal stenosis, it's usually on one side, not the other. So the classic is sciatica. On the left, we have sciatica. You see the lumbar and sciatic nerves come out. They form this tight cord, and that can be pinched either as it's leaving one of the neural foramina or by a disc. And so you could see in the middle cartoon, uh, the nerve root on the left or right uh, is named by the disc above, or excuse me, the nerve root and its dermatome is named by the vertebral body above. So coming in between L2 and 3 is the L2 nerve. Um, so that's why there are only 7 cervical vertebrae, but there's a C8 nerve. Okay, I hope that makes sense. So you can see these stripes of what will hurt or be involved in terms of the muscle innervation. L2, L3 is dark blue, L4 is lime green, and L5 is fuchsia purple. So you could just tell by history how which part hurts, which part is numb, where the foot drop, which nerve root is being impinged. And it's not just the disc that can cause impingement. Next to my head, you see the bone spurs growing into the opening or foramen can cause compression as well. And that's when you do the laminectomy. Above us, another illustration of dermatomes. The mauve is cervical, thoracic blue, lumbar yellow, sacral dark green. May not be known or appreciated, but muscles can also cause radiculopathy or pain in these nerve roots. Witness the tight psoas on the left. If the right psoas is too tight as a hip flexor, it's attached to the lumbar vertebrae and it can pull on the lumbar vertebrae, sort of like that, like an ice cream sandwich. And what happens if you squeeze on an ice cream sandwich? The ice cream squirts out the other side. And that's what we're seeing in this illustration in the middle. The disc is being protruded by that tight psoas. What's the cure to this? Well, one thing that can help is to lunge and stretch out that right psoas. Above us, another example of muscle causing sciatica. As the sciatic nerve goes under the external rotating piriformis, it can get irritated. So again, massage, red light, some kind of therapy could help with that. A lot of people have spinal stenosis, either cervical or lumbar. What is that? Well, I made this thing with AI of tires, and it just basically is meant to illustrate that the spinal canal is a potential space caused by the holes on these tires that are stacked on each other. So if the lumbar vertebrae or the cervical vertebrae don't stack concentrically, what do you get? You get sliding forward or back, or what the chiros call spondylolisthesis or subluxation. So that is a real thing. And what we see is that you can also get it from a fibrotic ligament, OPLL, but that's rare. It's usually just that the muscle, the torque, the ligaments, the alignment, something is damaged. And so the spine is no longer a tight stack of tires. Above me, an extreme example of this. This is the sacrum sliding backwards at L5. You can imagine nerves going through there would get kinked. And the kinking causes loss of bowel and bladder control. In the neck area, it will cause numbness, weakness, tingling in the hands and fingers. And in the lumbar, you can get pain and cramps in the legs after prolonged walking or standing. Typically, if they have spinal stenosis, they'll feel good leaning forward on the shopping cart or sitting forward. Now, this is a slide I show a lot about the FDA to illustrate a couple of points. First of all, 10 years ago, the FDA issued a black box warning saying you can get death, paralysis, paraplegia, blindness, no good. So that's just to cover themselves. Now, this is standard of care. So I've tweaked the paragraph above to read, Dr. Parkett and I have agreed that this injection may be appropriate. Steroids are known to have anti-inflammatory effects, but are toxic to stem cells. That said, there are no guarantees. It's not FDA approved. Yes, that's right. We're not talking about exosomes. We're talking about steroids in the epidural space have never been FDA approved, and somehow they do represent standard of care that's reimbursable. When you look at the authorities for evidence-based, the Cochrane reviews, it says from this study 4 years ago, there is limited support for the use of epidural corticosteroids injections, and the treatment effect is small, less than 10%, and the quality of the evidence, even supporting it, is poor. So that's what we're dealing with in terms of evidence-based risk, the FDA, and uncovered, or excuse me, illogical, sorry, what should I say? In terms of the standard of care of back pain, the doctors would rather do something than do nothing. So where are we if you have pretty severe back pain? Well, I would argue that again, prevention is the most important thing. Keep it healthy, reduce the inflammation going on in your body. The picture is from a video of a patient of mine who was taking TA65, and she does like 18 back bends from standing in a row at age 65. So there is hope. You can optimize with estrogen if you're a menopausal woman. D3, vitamin D3 is good, but only with the K2. Without it, you can get pathological calcifications and increased osteoporosis. And telomerase activation, I've been taking for 17 years. That can help optimize. Some people are believers in mitochondrial health these days. Try and limit the number of prescriptions you're on, etc. It's funny, these are the three surgeries you'll typically get. If the disc is protruding, they'll do a micro discectomy through this tiny, cannula, just basically cutting off the protruding part of that disc. A laminectomy, as we said, is when the foramen is tight from bone spurs. They'll go in and rotor-rooter out the bony canal. And then this last resort is Harrington rods. These are rods that go into the vertebral bodies and fix the back hardware of the vertebral body, so you can't really bend, rotate as much. And that will cause a cascade, increased erosion above and below the immobilized fraction. So much so that when they studied and asked 100 surgeons, 99 out of 100 said they would not have this lumbar fusion surgery. With regard to disc protrusions greater than 5 millimeters, they asked a bunch of doctors, would they do it? And, about 2/3 said if they were limited in their work 2 out of 5 work days, it was a 7 out of 10, then they would. But almost 20% say they would never have, regardless of symptoms or the disc protrusion, disc surgery, which is interesting. So why do we do lumbar epidural injections? Well, above me, you see what a lumbar epidural injection is. The epidural needle has a curve at the end. It's usually meant, like for the OB anesthesia, they put a catheter through. The epidural space is mainly a potential space, and you can thread a catheter up in there. If you keep on going straight, you're going to puncture the dura, or the watertight CSF sac where the nerves are. And so that's shown with the needle going straight forward. Now, the cauda equina is called the horse's tail, and it's shown here that about L1, T12, the spinal cord, which is like hard sugar cane, ends, and then it's a horse's tail below that. What does that mean? That the nerves are free flowing like linguini, so it's harder to damage them, unlike a solid spinal cord. And that's why we prefer procedures in the lumbar region. You can see from Netter's drawing that at the lumbar 5 vertebrae, the flat horizontal spinous processes create a really good space for us to go through. Whereas in the thoracic, they're angled, like sort of like a predatory reptile, hard to get into. C-spine is a little better, but they're very narrow. And you can see that in the picture of the different shapes of the vertebral bodies. Why not cervical? Well, you look at the front of the neck, you can see there's a lot of anatomy, a lot of nerves, arteries, veins to damage. Never want to do that. But even if you're going posteriorly, look above me. You see that the vertebral basal arteries go up through the area near the facets, and these can be nicked. So it's dangerous. I just met in Dubai a gentleman who's a brilliant doctor. He does a lot of legal defense, and he said that if you're a interventionist doing neck injections and you do C5, C6 injections, your malpractice doubles. A good friend from college is shown here in the middle. She went in for neck pain. I think it was a facet injection. And the doctor who had probably done 1,000 of these, unfortunately, got into the artery, not into the artery, but into the intima or the arterial wall, which, because it's a pressurized system, started to expand the dissection, and it went up into her brain and caused her to herniate her brain and unfortunately pass away. So this is tire country. You probably do not want to be injecting. Arguably, ultrasound is good because you can see flow and aberrant arteries. Fluoroscopy arguably is good too if you're using, real-time contrast dye, but nevertheless, should not be taken lightly injecting in the neck. So what is a spinal tap? Well, spinal tap is a tap beyond the epidural space into the spinal space. We can do that on purpose for diagnostic reasons to rule out infection, MS, or to insert exosomes into the nerve portion. That's the straight needle above me. But if we're going the epidural space, we usually use one of these epidural needles. That's the TUI needle next to me. It's kind of sharpish with a curve. These are three spinal needle variants. The one I tend to use is the sharp one, Quincke above. There's Whitaker and Sprott as well, which are labeled as atraumatic. Size matters. If you're using a big bore needle, you can get a spinal headache in up to 70% of the time. That's 19 gauge or larger. 40% between 20 and 22. I tend to use 22 or 25 if I'm doing a spinal. The epidural needles are 22 gauge. So bigger the needle, bigger the hole, makes sense, the higher the chance of a leak. A leak is a post-spinal procedure headache. You can say the incidence is 1 to 2%. It happens, even if you're not trying to puncture the dural sac. Mistakes happen. It will usually resolve in a day with horizontal rest, fluids, caffeine, time. It's felt as a pulsatile severe headache that's really only felt sitting up or standing up. Um, if you need to, or if you get scared, you can do a blood patch. Uh, it's not really clear what the ideal time to do that is. If it persists after 1 day, 2 days, 3 days, usually helps within 24 hours of the first blood patch, and rarely do you need more than two. All that is you get a little of the patient's blood, you inject it through the epidural needle in the same space, and it gets in the epidural space and forms a clot and patches it up enough to stop the headache. Question I get asked a lot is ultrasound and fluoro. Well, fluoro, it's radiation. That's not great. The dye also not great. Could be reactive. Ultrasound is great for measuring the distance to the posterior complex. So what does that mean? We put the ultrasound on the back, hopefully in position or kyphosis, bend forward, and you can measure the distance to the posterior complex, which is the back or the ligamentum flavum. You can see in the middle of this, the spinal cord is that spinal canal formed by the gaps between the holes, the big holes, and the anterior complex is the front. So if you know that it's roughly 4.2 centimeters to the posterior complex, you'll be more confident as you do your procedure. But as far as the real-time fluoro, not sure that it's worth that. The landmarks, which we'll go over in the video, are shown here. The iliac crest, or the tips of the ilium, usually transect around L4. So that's a good way to figure out where you're at. Every time I do a procedure, I mark the iliac crests. You can see that on the lady in the middle. And then I mark out where the venous dimples are. That's towards the top of the sacrum. And you could count up L5, L4, etc. And so that's really nice to be able to find out exactly what level you're going in. When you're doing ultrasound, if you have it, there's also three ways to visualize. If we're in the very midline of this sagittal plane, you're going to feel the bumps. You're going to have the ultrasound over the bumps, and that's going to be bumpy. If you have these rounded areas, It's where you're at the facets, and that might be important if you're injecting the facets, which is very possible to do if you have an ultrasound in real time. That's really the only time I would use an ultrasound. And if you slide out blue laterally, you'll find just these little bumps. That's the transverse process view in the sagittal. So let's go over four cases. One case is a long time ago, 5 years ago, flew out to New York to treat a 41-year-old man. He was a weightlifter. He felt he had pulled something in his low back. He also worked as a water damage building mitigator. Who knows if that's causing inflammation? Chronic low back pain, and it was localized to the quadratus, in his opinion. So we did a injection in June of 21, 10 billion exosomes. And the reason I used ultrasound is because the QL connects the iliac crest to the transverse processes and the 12th rib. You can see it there in bright red. But if you're injecting and your angle is bad, you can go intraperitoneal, damage the kidney. So, but if you do some views on YouTube, you do a little homework, you can see that an ultrasound will guide you perfectly. It'll guide you through the external oblique, the internal oblique, transverse abdominis is towards the side. And you'll see this QL massive muscle. And that's right at the periphery of the transverse process. So it makes it an easy, safe procedure when you're going in plane. He subsequently ended up with L3 arthroscopic facet surgery. So who knows what complex things were happening with the QL in spasm because of localized pain, facet arthritis. They had to do a lysis adhesion, and indeed they did a nerve ablation, which, I'm not that big a fan of taking away the pain, take away the source of the pain. Case two and three were broken backs. The lady, case two, is a 63-year-old woman. She was water skiing, sudden acceleration of the torso and the lower body jackknife, and basically she heard a pop. And her x-ray showed what's in the cartoon above, just the L5 was crushed like a beer can. So for 7 months, she felt a crunchy feeling when moving. She had some dull referred pain in her hip flexors. So we did just 6 billion MSC exosomes at the L4, L5 epidural interspace. It must have reduced the inflammation, perhaps helped to regrow some of the bone or whatnot. I don't know, but her pain went away and it's been gone. She did have a wet tap. I went a little too deep. You could see the CSF just running on the floor. Luckily, within a few hours of bed rest and hydration, it was gone. Case number three was an interesting one, which taught me that in the case of acute inflammation, case two, 7 months of chronic pain, low-level inflammation, she had osteoporosis and fracture. And so that maybe would have done okay with IV. But the lady in case three had fallen off a horse in Tulum, broken 5 vertebrae, all significant crush injuries. And so she was scared of the epidural and said, I'm not never going to do that. Went to someone else, got an IV, a 15 billion IV. And indeed, within 2 weeks, it must have gone to the area of inflammation and healed it somehow or reduced the inflammation such that within 2 weeks, she was in the gym exercising and her pain was completely resolved. Case four is very typical. It's a 43-year-old man, chronic low back pain, some MRI, disc bulging. Also has cervical dysfunction, cracking, and some C-spine disc issues and spinal misalignment, not approaching stenosis. But we did L3, L4, 8.4 billion exosomes. Back pain resolved. He's gotten two additional epidural shots just to strengthen. But what's interesting is the neck clicking also has resolved, which is a bonus. And why would that be? Because the epidural space is a potential space. It communicates up and down, forward and around. It obviously communicates to the nerve roots. That's why you get an epidural anesthesia, but it also can contact the discs, ligaments, and the bones. The question about whether it gets to the facets, maybe, maybe not. There's something called the retrodural space of Okada. In some cases, sometimes it can get to the facets. I probably would argue that if you're doing a facet specific disease, use the ultrasound to go right in the area of the facet. Also, if you're doing like sympathectomy or sympathetic CRPS management, paramedian is a very easy injection as well. You can Google that, look it up on YouTube. Above me from Latvia is an interesting study. They did cadaveric epidural injections, and they showed with this purple or a blue dye that the epidural space is a potential space. It'll leak up and down, so it'll go migrate all up and down the spinal cord. So, yeah, I would say that in general, the people, I would say over two-thirds are happy, they're better with back injection. But because the back is such a complex, hard-working structure, one shot may not be enough to get you where you want to go. The written protocol, of course, as usual, all online course members have access to these protocols. They can download them. We have the videos, which all except the hip injection. I will eventually get your hip injection video. They're all up there, and future training will be posted as well. The highlights of this procedure sheet are I like to have people sitting up. I don't like them lying decubitus or recumbent because you can get that extra curvature. I like to know where the spine is. So they'll sit. When we're doing the procedure or we're marking, we'll have them curl because the anatomy of the skin in relation to your approach will change. So you just say curl like a shrimp or an angry cat, cat cow, like a cow. I'm sorry, like a cat. And so basically you just do your markings. You mark the iliac crests, venous dimples, 5-4. You mark a big X where you want to go with the pen cap impression. And then you're going to be prepping, put on your sterile gloves. And then the rest of it, the highlight of this is just that the exosomes are in a vertical syringe, probably a 5, but this is the only one where I'll use a 3 cc syringe in a non-local anesthetic capacity in order to not mess up and have to like taste the solutions. Lidocaine is bitter. Exosomes and saline are salty. Uh, I orient the syringes. So exosomes vertical, lidocaine horizontal on my sterile field. But in this case, we have to use a 3 millimeter because in this case, we have to use a 3 cc syringe for localization because the tactile feedback is too poor from the larger or smaller ones. So this is the only exception where we use 3 cc syringe for something other than lidocaine. So we use normal saline, and we'll put normal saline in that diagonal or acute angle syringe and put it next to the epidural needle, and that's what we use to find the epidural space. So once we find the epidural space, remove the stylet, replace with the syringe for exosomes, and that could be diluted up to 5 cc's. Again, increased volume might help diffusion, but these are so small, they will naturally diffuse as well. So that protocol is described there and on the course. After this, we'll watch the video together. Hopefully, it'll work this time. Hopefully, I've figured that out. So, in terms of orienting, keeping things straight, like the Leaning of Tower of Pisa, you see my kids 10 years ago trying to push it back. Maybe we have some magic in these vials that can help us to realign it. But if you take the course, I got a little punchy, so there's a lot of pictures of art history. So you might pick up some art history pictures of my kids back when they were cuter. And obviously you have all the videos, protocols, forms to download and customize, training, and it's a great resource for you. And every dollar you spend, you can get back as exosomes for you and your loved ones. We all wish that we can do a camel like this woman that represents a good, strong, healthy back, which, our chiropractic doctors and osteopathic colleagues will tell us is a very important thing to stay healthy. And I would tend to agree. So my books are Exosome Songs of Healing in audio and print and ebook. For Hay House, I did a great book called The Telomere Miracle, which talks about all the free stuff you can do to keep your telomeres healthy. And my first book about a dozen years ago was Telomere Time Bombs, where I came up with this theory of the stem cell theory of aging. And yeah, that's about it. So let's watch the video and then we'll take some questions. Let me stop sharing this. How do I do this? Un momento, por favor. Stop sharing. So before we put on the sterile gloves, we're going to prep. You can see I've marked the iliac crests. That's the first thing we do. And then we find the venous dimples. That's toward the top of the sacrum. And then we feel for the spinous processes, L5, L4. And then we put a pen indentation so we know where we're going to inject. And then because the betadine kind of cleans off the marking. Oh, where's the fan? Okay.
What's the X?
X marks the spot. So we know just generally where we're headed because we wipe off the markings there. So even if I wipe off the markings, I know I'm somewhere in this area. Because once we get the sterile gloves on, we don't want to touch anything. So this is
What are those points out there in that one?
Oh, those are numbers. That's 4 and that's 5.
Oh, got it.
Yeah. So the betadine needs to dry to be fully bactericidal. All right, so that's good.
Oh, that's the Lido.
Yeah, so we're just going to infuse the Lido a couple millimeters. We can go right in the midline through the ligament, or we can go a little to the side, either way. She doesn't have a lot of scoliosis, so that's good. Okay. So we have 2 syringes. This one's to find the epidural space. So that's usually the black markings, 1, 2, 3, 4. So it's usually right about the 4 centimeter mark. This is not exosomes, this is saline. So we're gonna go the bevel up. And okay, you shouldn't really feel this. So we go to about 3 centimeters, take out the stylet. And we have our normal saline that we're going to use to find the epidural space. So you feel a little, it bounces, and then it'll lose resistance. Right there, we entered the epidural space right there. 3.5, 4 centimeters. I'll just make sure that we're in a space. Yeah, no resistance. So when you had your babies, this is what they did, but they at this point they threaded a catheter in there, but no catheter needed. Might feel some pressure in your legs. You good?
This is saline.
No, this is the exosomes.
okay.
Yeah. And that's it. So she's got a pretty shallow one. It's only about 3 centimeters. Usually about 4. Good, you done.
Okay.
All right, so we're gonna.
That was much better than the first time.
Okay, anyone want to ask a question? Oh, there was a question. Why do you think lumbar epidural injection should be better than lumbar intrathecal? Well, in most cases, the back pain is due to discs. So if we put it in the intraspinal area, it's not going to go to the discs. So we want it to flow to where the problem is, meaning the disc inflammation, protrusion, damage, and ripping. So that's why we do epidural, not intrathecal. If I'm trying to help somebody with a stroke or something like that, get to CSF, then I'll do intraspinal. Are there any studies or reports more than just patient reports? Not really. I don't think that this is one of those procedures, unlike heart attack, stroke, arthritis, that people have a good animal model for. But in general, I would say anecdotally, 2/3 to maybe 3/4 of people get a significant improvement. So that's good because epidural steroids, there's no reason why they should work. The evidence isn't there, but everyone does it. I would argue it's probably setting up for more discogenic problems, ligamentous problems, osteoporosis. Question, Anita, how many exosomes do you typically use? They're billions or trillions? Now, trillions is particles. Usually people are in the 10 to 9 range, meaning billions. So that could be 1, 10 billion. Sometimes these companies allege they have 100 billion. Maybe they do, maybe they don't. But in general, volume, there's some interesting studies saying if you do 6 cc's better than 3, in some ways 3 might be just as good as 6. I usually do 5 cc's, so depending on what I'm using, I might dilute up to 5 cc's because you want to open up that potential space and get them moving up and down, help all the discs, all the ligaments in the area. And even like that one guy, all the way to the neck, it will get up there almost like, food coloring on the edge of a paper towel will get all the way up there. So to answer your question, the brand I use is generally used to be denominated in billions. Now they're talking particles of trillions. But for my internal use, I would like to do at least, the minimum 1.4, but I think 4.2 is good. 8.4 is probably ideal. That's 2 cc's. You could also just take a straight 7 billion in a 5 cc, and that will be a nice dose and a nice volume. Any other questions? Yeah. So I know people typically don't like the idea of getting or giving injections in the back, but because I came from OB, I'm more used to it. I mean, we have people with giant abdomen screwing in pain and screaming, and somehow they managed to get it in there. Were they without complication? No. Yeah, even the anesthesiologist will say it never happens. A lot of people did have persistent back pain, probably because the veins are so big in pregnancy that they got like a hematoma. But with this, you're not threading a catheter. The person's not writhing around. They're not anticoagulated, or they're not pregnant. And so it's pretty safe.